The following podcast is a Dear Media production.
Hey, Tism Talk, how do we feel about this spoon?
OCD is you're uncomfortable. OCPD, you make other people uncomfortable.
Can narcissism overall be genetic?
On the ADHD side, how does it generally show itself differently in men and women?
I think one of the most common things that can really hurt a couple is when someone says,
Wild Til. Are you ready? Yep, let's go home.
Hi guys, welcome back to the show. Joining us today, we have Dr. Eric Bender, a triple board certified psychiatrist with a psychotherapy practice based in San Francisco and a feature host of GQ's The Breakdown, a digital show discussing mental health depictions in film and TV. Welcome to the show.
thanks so much for having me. It's great to be here.
We're so excited.
On the right over here, we kind of got a little bit of information about you, and I think I'm learning more about you as a person, and you have more depth to you in and outside of medical than I would have ever imagined. But can you give us an overview of how you got into the profession you are today and what that looks like for you?
Sure. I grew up in South Jersey. I always start there because I feel like I need to defend New Jersey. It's not always depicted on TV the best way. So I grew up in South Jersey, and my family was very much a service-oriented family. So at a young age, I learned, okay, we can try to help others, and that's a good thing to do. So over the years, I was teaching, I was tutoring. And after college, I did a volunteer teaching year and really enjoyed that, but I wanted to find a different way to help people. And so then I did some social work, and I was working with the elderly Italian population in San Francisco.
Okay.
Wow.
I used to know Italian. It's very rusty now. But I would go to people's homes and bring them to appointments, Social Security, you name it. And I was accompanying a woman who was very anxious to her physician, and he was not treating her very nicely. And I remember thinking, I think I can do this a lot better than this guy is doing it. So that actually started to spur my interest in maybe I should look into medicine, but I hadn't had any science classes since junior year of high school.
Wow.
So I did not do any pre-med in college. I studied
Wow.
social history, children's literature, pop culture.
But you mentioned you getting into medical field late. What is late?
Late means what they call a non-traditional student. So someone who comes from a different background that's not science, or maybe took a few years off and did things. I was that. I had done this teaching. I had done some social work. And so I applied later to be in medical school and was luckily accepted. But it was not easy, and nor do I recommend this to your listeners, to go to medical school with only 4 science classes to your name.
Okay. Under your belt.
Yeah, so I took physics, OChem, bio at the same time, and general chemistry, took the MCAT all in the space of a year, and it was hard in medical school.
I
I
bet.
can't even imagine. Growing up, did you have a family that was transparent and honest about mental health?
I did in some ways.
Okay.
And I say that because I think it's true that when you see somebody upset, you recognize something is wrong. So people definitely showed emotion. But in terms of how to express it and in terms of how to actually share that with other people, that was tougher. And I think that actually spurred me to want to become a psychiatrist. There's this idea in psychiatry that if you're becoming a psychiatrist, maybe there's somebody you're trying to save. Like maybe you had a family member or friend. And then there's an idea that if you become a child psychiatrist, maybe you needed a child psychiatrist as a kid.
Right.
So without getting too much into my own personal background, I will say that there was definitely motivation to help people manage and discuss emotions and give a place for it.
That totally makes sense. I would love to hear the difference between a psychiatrist and a psychologist.
Sure. And this is something I didn't know till I went to medical school, but a psychiatrist goes to medical school and can prescribe medication. A psychologist typically goes to graduate school and usually can't prescribe medication. And I say usually can't because there's some states that have a shortage of psychiatrists.
Oh.
So there have been petitions to allow psychologists to take pharmacology classes and then eventually be able to prescribe.
Oh, interesting.
But the main difference is psychiatrists will go through medical training. So I've been through surgery rotations. I've been through internal medicine rotations.
Oh my
I've been
God.
through all that stuff. OB-GYN, you name it,
Yeah.
I did it. So that's one thing that gives you a breadth so that when you are talking about medications, because we can prescribe, it helps me think about other medical issues people might be going through and think, okay, well, maybe you remember taking medication like this. This is a little different, or you might have experience in surgery or have had a recovery. This medication will interact in this way. So it's helpful to have that background.
Like going back to kind of like the specialties that you've kind of talked about, being triple board certified, which I learned about 5 minutes ago. Kind of speak to how you ended up in these 3 categories.
Sure. So general adult psychiatry, that's the pathway that if you're going to study psychiatry, you go down. So everyone starts there.
Everyone
starts there.
Okay.
General adult or general psychiatry. Now, you have some exposure to treating kids during that time, teenagers, maybe couples or families, but it's general adult and you treat people 19 and over, or 18 and over. If you want to do more training in psychiatry, let's say you're interested in addictive psychiatry or addiction and drug abuse, you can do an addiction fellowship. Fellowships are additional training. You can do geriatric psychiatry. There's also what's called consult liaison psychiatry, where if you work in a hospital, the other teams that need psychiatric input can call you, and then you can go give that. I decided to pursue child psychiatry because I really enjoyed when I was teaching after school. That was my favorite time with the kids because then they were unplugged.
Right.
I got to see them, what they were talking about and what they were thinking about, and that was really interesting to me. And just to back up a little bit, in med school, what was interesting to me was how do people tick? I wasn't so much interested in, okay, tell me about your heart medication and let's talk about your murmur and let's talk about this. I wanted so much more to know about
your
this
murmur.
person. Yeah. So
Riveting.
yeah, exactly. My eyes would glaze over. So it was time to do something where I could really dig into what makes people who they are. Yeah. And so that led me to general psychiatry. Wanting to work with kids led me to child and adolescent psychiatry. And then forensic psychiatry I just found interesting. Yeah. That's the intersection between mental health and legal issues. Mm-hmm. So imagine someone has been accused of committing a crime and their attorney thinks that at the time of the crime, maybe a mental illness played a part in them not knowing what they were doing or not knowing what they were doing was wrong. Then I'd be brought in to do what's called a sanity evaluation and evaluate, was there something that was getting in the way then? Or if someone has, again, committed a crime or been alleged to have done something, is there a mental illness that's preventing them from working with their attorney right now? So then I'd be brought in to do a competence to stand trial evaluation. And on the child side, it gets kind of ugly. That's where you do custody evaluations and you're interviewing, and it can get unpleasant there. But it's interesting to me. That's an interesting subject matter, all of it. So I wanted to do that too.
Like that there's a lot of responsibility there. I mean, I feel like you're being given a lot of power almost to help make really important decisions that are fundamental to kids' lives.
Yeah. My wife said to me once, do you realize how much power you have as a psychiatrist and how you tell people what you think of them and what you think? And it's always something I try to remember, not just in the forensic setting, but even in the clinical setting.
Yeah,
in the
absolutely.
office.
Well, you mentioned it or you referred to it as a privilege, which is really cool.
I really remember that. It's a privilege to sit with the patients and see them at some of their darkest moments, and also to hear about their exciting moments, getting married, having kids, getting promotions, selling their companies, those kinds of things. And I always remind myself, it's really such a privilege. And then people do share hard moments. Yeah. And I feel really lucky to be there with them and that they trust me.
I had a therapist, and I think he would have been a psychiatrist, now that I fully understand the difference. He was a psychiatrist. But thinking about how you're talking about like the privilege and the weight of the words, I have a tattoo of something that he said because it resonated with me so much and literally changed the chemistry of my brain and the way that I was able to process things. And I just think about how true that is and how deeply meaningful his words were to me.
Oh, that's great.
Was it?
Can I ask what it was?
Yeah. Okay, so I have just a generalized anxiety disorder and I have a metaphobia. So I've got a specific fear around the possibility of getting sick. So it's not actually the getting sick, and I'm sure maybe you've encountered this. So he, through our work together, helped me understand the idea of what if that happens? Okay, if that does happen, then what? So it's like the idea of just what if, then what? And so we would walk my anxieties back to the furthest point of what I consider to be the worst case scenario. And every single time we broke down a situation that I had deemed as like impossible, I was able to get myself to a place where through every single step of the what if, then what, what if, then what, what if, then what, that it really was not that bad. And it literally changed the way and rewired my brain and how I was able to process some of those situations.
Wow. That's awesome. That's really good. It sounds like what you were doing was called cognitive behavioral therapy, where you look at the vertical downward arrow, like, and then what? And then what?
And then what? And then what? And at the bottom, I was like, wait, it's actually not so. This
not
deep
dead.
abyss down here, I thought was literal. The worst case scenario is not so bad. Yeah, no, big fan of CBT.
That's great.
Yeah.
That's really great.
See, that's what CBT means.
Cognitive behavioral therapy.
I hear that like acronym thrown around. Never put those two together. You know, that's like at a certain point in time, I've heard it too many times. I didn't ask.
Right,
I'm like, well,
now it's too late.
Can't ask now. Could have just Googled it. You seem like somebody who's like, if you started things late, quote unquote, but also are very much in the prime of your career. What are some of the things that you have heard or learned about recently that maybe didn't exist even in the beginning of your career that you're excited about, that are new, that like maybe haven't been fully tested? Maybe they're not like the standard yet, or some of the exciting things that are going on that like only someone who's in your position would be really excited about, hoping that information continues to kind of like come out to the general public so that you can help your patients better.
I've been really interested and excited to hear more about what everybody's talking about, which is psychedelic use in treatment.
We have questions about this.
And I'm sure you have questions about it. People are always, I think in some ways people are eager to say, oh, can I legally have a trip and like see what that's like? But what I always say is that first off, there actually were case reports of people who didn't stop taking their antidepressants. So they didn't fully have the psychedelic experience, but it still improved their depression.
Right.
So that's what I'm interested in. It's not so much the trip and all that, but that people can get better and can improve. And also, a lot of times in these types of treatments, it's what's overlooked is the bond that someone has with the provider. And in those psilocybin studies, taking that increases a tendency to trust people. So then you can actually trust someone, especially someone who's really maybe say traumatized or unable to trust others. The idea is you can trust someone and then you open up, you start to talk more. And then maybe you can build on that relationship. So I really think there's a lot of promise there.
Yeah.
I think in things like deep brain stimulation, which has been around for a while, it's to treat movement disorders like Huntington's disease or things like that. Like, are there areas of the brain where we can realize, oh, wow, this happens here. And maybe if we stimulate that in some way, we won't be able to have people suffer with this, whatever it is. And I think that's heading more towards mental health issues too. So I'm excited to see where these things go in the future.
It's crazy how little we know about our brains, from what I understand.
Yeah, we don't know a ton.
We know a lot, but
even
know little.
I'm sure we'll talk about medication. We don't know exactly how they work. We have thoughts about it. We know what improves, but we don't know everything. Yeah. So I think it's exciting just to see where things go. One other thing that's exciting for me is the work I do looking at pop culture and mental health. There's now people crave that. When I first started doing this about 16 years ago, people were like, that is the stupidest thing ever. Like, why are you talking about Darth Vader?
I don't want to hear about this.
Like, one of my teachers said to me, Darth Vader having borderline personality disorder, that is the stupidest thing ever. Why are you talking about that?
Classic.
And I remember thinking, wow, I really like this teacher. I wish they could have been more supportive. But I think the excitement people have now to talk about this, the openness, it's really, really cool to see that that's developed too.
Cool.
I think there's also a level of comfort too in watching a show where you see yourself embodied in a specific disorder or whatever it might be, a mental health condition on TV. You know what I mean? I think it normalizes it and creates a sense of, comfort for me. Like when I see an anxious character, I'm like, God, there I am on TV. Well, look at me go.
But alongside every television and every movie show like ever, having someone throwing up, which I didn't realize until I was with you.
It's crazy. And so Jeremy obviously has learned a lot about emetophobia since being with me, but it is wild how in every single show and movie someone throws up at some point.
Someone in every like writer's room goes, they should throw
up here. And we should throw up here.
When it happens in the real world, I just start like screaming really loudly so that she can't hear like the noises. I don't know if it helps, but it's what I do.
No, it's good. And depictions of vomit have changed over time too, you know? So
that's great.
You're right that it's in every
I'm not sure
show.
why. Like, they're like, no, we have to have this moment.
It's so cinematic. It's a must have.
And whoever the voice actor is on that day, they've earned their money. I'm always like,
oh God, I can live without it. We had a lot of questions about the difference between recognizing when you're just feeling sad and when you're experiencing true depression, or when you're feeling, regular life stress, or when you're feeling anxiety that should be met with more, serious help or counsel.
Sure. Those are great questions. I think first of all, everybody feels these emotions. I've run into in my therapy practice, a lot of people have, whether consciously or not, have pushed away every emotion. So I think, first of all, recognizing that you're actually feeling something for some people is the first thing.
It's a good thing.
Yeah, it's a good thing, yeah.
It's recognize they're feeling sad, they're feeling angry, they're feeling whatever it is. But what I learned and what psychiatrists and mental health professionals will tell you is that when something starts to get in the way of you functioning the way you want to, when it gets in the way of how you go through your day, then it can be labeled as a disorder. That's when it's more concerning, when it's getting in the way of you going out or being around a sick relative or something like that. Those are times when it's important to get some help, to reach out to somebody and just talk to them about what you're going through.
It's such a simple way to break that down. Like, is it getting in the way of you functioning in your life? Like, that's huge.
when my medication wasn't right, I was functioning at 10% capacity.
Yeah.
Literally 10, like it is such a night and day difference.
I imagine I felt terrible, just to go through like
It was
10%.
Literally, it was so awful, especially because of the contrast of knowing what 100% of life felt like and then being reduced down to 10%.
Yep.
We're back at 100, so we're good, but it was definitely a rough time.
I also think, like, I remember you just being very almost overly apologetic to me of just like how you weren't the version of you that you wanted to be. And like, that was like another, it's like, I feel bad internally. And now I feel bad because of what's happening externally. It multiplies.
But that's one of the criteria for depression is a guilt, not because you've robbed a bank or something you should feel potentially guilty about, but an internal worthlessness or feeling like you're not good enough. There's a guilt that happens.
Yeah. This is more of a selfish question, but on the ADHD side, because it's something that I've been diagnosed with, how does it generally show itself differently in men and women?
That's a really interesting topic. So I'll go with some anecdotal things and how I've seen it and what I see repeating. A lot of times I think it's underdiagnosed in girls. I think that it goes overlooked. So just to back up even more, ADHD is attention deficit hyperactivity disorder. It used to be called ADD, attention deficit disorder. And then before that, it had this long name that thank goodness was changed called hyperkinetic disorder of childhood.
Oh, that's super catchy.
Yeah.
I'm going back to that one. Yeah.
So they've changed it. Those people that have written the diagnostic criteria, it's now all under ADHD, but there's two types. So there's the hyperactive impulsive type where it's really hard to sit still. Someone's running around in situations when they're not supposed to be. And then I'm thinking about a kid. In an adult, it'd be more restlessness.
Mm-hmm.
They have a really hard time taking their turn. They might be blurting things out. They might be talking nonstop, seeming like they're driven by a motor. Those are some of the criteria for the hyperactive impulsive type. And if you have 6 criteria, you can meet a diagnosis for that. On the other side, you have what's called inattentive presentation. And what that means is that it's hard to focus on things. You don't pay attention to details, might make careless mistakes. If you're given instructions, particularly multiple step instructions and oral instructions, it's hard to follow. You might have to write them down. If you ask a kid, go upstairs, get your pajamas, brush your teeth, and go to your room. You go up there half naked, they're playing with something, listening to music. Like that's the kind of thing that happens.
I think you're actually depicting his childhood. Yeah.
Okay.
I'm not going to take this.
So in addition to those things, then you also see someone might talk to that person and you're talking directly to them, but it seems like they're not listening. Like they're off somewhere else. Tasks that require a lot of attention, often the person will procrastinate, maybe not even get them done. They might lose things repeatedly.
Again, I'm right here.
Easily distracted. So that's the hyperactive. I'm sorry, that's the opposite of the hyperactive. That's the inattentive presentation. Now, if you have 6 there, you have a diagnosis there. If you have 6 on both sides, hyperactive and inattentive, you have combined presentation. They're all treated the same way. But I'm giving you all this background because in women and men, I think in boys, they tend to be more rambunctious. So it's easier to see the kid climbing the walls, or the stereotypical image you have is probably of a boy who's doing things that seem to fit the hyperactive picture. Girls tend to be more on the inattentive side, or if they are on the inattentive side, it's just assumed to be that's what girls do. They're quiet. They don't necessarily make noise. So I think it can get overlooked in girls. It's more frequently diagnosed in boys. And then in adulthood, I start to see it more similarly. Like people are losing their wallets, losing their keys. They're not making bills and paying them on time. Their marriages are tough. Spouses are getting mad you're not listening to me. And that's how I see it kind of come together.
Before you got here, there was a bowl of baby carrots on a random side table upstairs in our bedroom.
Okay.
It's like, and this is ADHD husband in its prime.
Like if you saw like all of the things that are semi-important in my house, there's a tag or a tile on all of them. Like I have like a thousand webs of
tracking.
Just like, where's this stupid thing? 'Cause, like, you have to find systems that work.
Absolutely. And that's what people come to me, usually to a point where their systems are not working anymore.
Yeah.
Right.
Especially adults. And you can carry forward with your systems to a point, but there's a point at which it's really hard. So for some kids, that's like 6th grade, might be even 2nd grade. For some adults I've seen after graduate school in the middle of their thesis, they're getting diagnosed, or after medical school because they had ways to get through, but somehow the volume of things got too big.
New environment, I always feel like is like my framework doesn't work here, but I've got to figure out how to make whatever was working before make sense here. And it wasn't always that easy.
Yes.
And then I can think selfishly again, and this is like going back to like the childhood thing. Although I do think I was more on the inattentive side than hyperactive, I I do remember always feeling like I have this, and it wasn't until TikTok, this superpower of knowing where people were going with whatever they were saying, to the point where, of course, I'm cutting people off. And I didn't realize how common this was until I saw a TikTok of someone like talking about this. And like, I knew what they were going to say, so I cut them off. Assuming that I don't have the superpower of seeing into the future, which if you think I do, feel free to tell me. Is that a common phenomenon?
Yes, that's actually one of the criteria is, do they often interrupt others?
Yeah.
And so that's on the hyperactive, impulsive side.
So I got from both categories. That's good. Yeah. I'm
That's
a lottery winner. Yeah. I didn't realize how, like, I genuinely thought I must be able to tell the future, obviously, because I know they're going to say. I'll just cut them off and get to their point.
No, that's perfect. That's totally socially acceptable.
People love when you do that.
How do you think social media has, I know this is kind of a broad question and could be answered, I'm sure, a ton of different ways, but how is social media impacting our mental health as a society today?
There are studies that actually look at this. So to a point, social media can actually make people excited and connect with others and they can feel good about it. But there's a point at which, after a certain amount of time, it actually goes down and your happiness decreases. I think that's when people start thinking, I don't have the life these people online have. I don't have the beautiful vacations. I don't have the cars. I don't have the friends. I feel left out. So I think it can help connect, but it can also really make people feel isolated. Yeah. One of the things that I think has happened over time since the internet's come around, when kids were growing up back in the 80s, 90s, before the internet really took off, and before then, if they were getting bullied at school, they had a reprieve at home. Right. They could go home and it was done. But now there's cyberbullying, there's 24-hour nonstop. People can make comments at any point, and not just for kids. Like, look at the society we live in. There's all kinds of bullying comments that come around any time of day. So I think it can make people feel very anxious. I think it can also make people feel uncomfortable. So I think that's a big part of what I see for social media, and kids feeling like they should be feeling a certain way maybe, or they should be with this group. And if they're not, then there's something wrong with them. So I think it makes for a lot of confusion for some people too.
Like TikTok, obviously, you're not supposed to be but under 13 before you have an account.
Yeah, I think it's 13 for TikTok.
In your like, I guess, thoughts, like, where are our brains at 13? Is that a number that they threw out randomly? Or like, if you had the power to, like, no, 15, 17.
I'm guessing 13 probably matches with PG-13, something like that. Like, okay, that sounds like a teenagery age, and we can...
Teenagery age.
Yeah, 13 sounds good. But like, I guess, is there a number for like boys and girls when like you could be more safe?
Well, what we've learned in the last few years is that adolescence goes beyond just 18, 19. It goes into the early 20s. That's when the last part of your brain to form
25
happens. Yeah, some say even mid-20s.
Yeah.
But that frontal cortex gives you the ability to do what's called executive functioning, where you organize things and you put things together. And this is I'm sorry to keep going that to your side there, but this is what has happened. So no, a 13-year-old doesn't have the ability to say like, oh, this is somebody's opinion. This isn't gospel. This is something else. So yeah, I don't agree with 13. And I think that parents, and I tell parents this because I see a lot of people, either because I'm seeing their child, then I meet with the parents, or I see the parents individually and they just happen to have kids and they ask me about stuff. Know what your kid's on. If they're using TikTok, be in the same room. Ask them to show you. Like, they're probably not going to want to, but maybe that's a condition by which they can use it. Right. So, be in the same room and see what they're doing.
I can't imagine being, again, having my frontal cortex, precortex?
Prefrontal.
Prefrontal.
It's prefrontal is part of the frontal cortex.
I got more in my brain than I ever do.
Oh, man. I just can't imagine having social media be such a big part of my life at such a young age. Like, even having my career on the internet, I didn't start posting content until I was 19. And even then, just like the idea of being perceived by so many people at all times is a lot to process.
Yeah.
But also, even then, there wasn't as immediate like gratification. Like remember dial-up? To get onto the internet, it took 10 minutes.
Like, be patient.
And if someone had to make a phone call, that's the end.
Yeah, like having to go out of your way to like log on to a system on your desktop to like say something mean about somebody. Like, there's just more steps there. Now it's just so easy. I don't even have to type. I can just translate. Like, this is stupid. Send. Like, it's too easy. I feel like for people to I feel like let that wall down.
Yeah, I think also too, it's like you see especially like in young girls. Like, I feel like I see young girls looking so much older than their actual age, and I agree that I think the ability to connect and learn, because there's like, I think about, I was such a crafty kid growing up. And if I had access to YouTube and the craft tutorials that were available at my age as a child that are available now, like it would have been incredible. But like the darker side to that is just the, the dangers of all of it. It's so scary.
I do see schools teaching more about this to kids, and I see some young kids being like, oh no, I know not to go on there, or I'll turn off the chat, that kind of thing. And we're teaching kids now, don't reach out to anybody you don't know. And if people reach out to you, you don't have to respond. Actually, it's better not to. So it's being taught. Now there's this whole almost hygiene for the internet for kids.
Absolutely.
Hygiene for the internet. I love that.
It's true. It's like we have sex education and barely in America. Like we should have social education.
Yep.
We really should.
Yeah.
I know that you have clients that come in as a couple. So we would love to hear from your perspective what you think couples are commonly getting wrong when they're coming to you to support their partners.
I'll say this, and I know people might be like, what are you talking about? But I think one of the most common things that can really hurt a couple is when someone says, well, I really want to make him happy. I really want to make her happy. It is not your job to make your partner happy. Like, don't beat them over the head, but they need to be able to take care of their own emotions. And if you find that can really drive a wedge between two people.
What's that look like in practice?
The distance that can happen.
Just like
I guess like, someone trying to be the happiness provider for their partner.
In the best of it, that they think that this is what they should be doing, and they're putting themselves into that.
You can see it in a wide range of, just like anything, there's a spectrum. Somebody might give up a hobby because, their partner doesn't like them coming home late. Somebody might stop something they really love, or not cook or not bake, or then it goes to not working and not pursuing your own professional interests. So I think there's a wide range of things that can happen, but I will often say to people, so where did you get the idea you're responsible for making him happy?
That question,
happy?
I can only imagine what people say.
Yeah. And it usually actually makes them stop and think. And that's what I want to have happen is I want to create a space where people can think about how they're interacting with their partner. And I also want to create a space where each person can think about themselves and the other in ways they haven't before. So looking at, why do you think this way? Why might you not want to do that? Or why does it feel so important to make somebody happy? And then oftentimes you learn that was their role as a kid in their family, was to make sure they did everything right, make sure that everybody was happy with them. If somebody's unhappy, it was dangerous. It meant something in their mind could go wrong. And then you do the downward arrow of, well, what happens at the end? So you look at those things, and it can really be enlightening for one person to say, I never knew you thought about it that way.
Right.
It's like, I've always thought this.
Yeah.
It feels so right to think this. And also, I just love, I feel like even we've just discovered between each other, just like the different things that we look at something, we know that it's the same thing. We even spiritually, we feel that we're on the same page, but just like the way that we come to it is just fundamentally different. And I feel like the amount of times I've been like, oh, I don't know. I didn't like that as a kid. Why am I continuing that now? But until somebody else calls it out, it's really hard to see that about yourself.
Yes, absolutely. And so those kinds of things, I'll try to pick up and say, wait a minute, I feel like when you're saying that, I wonder if you're telling me this. Is that something you think? Is that something you feel? And then they can correct me, which is great, because that means they're starting to feel comfortable enough to say no, and they're starting to push back. Or they'll say, yeah, actually, that's exactly what I feel like. And then the partner will turn and say, I never knew that. And what was that like? And then you get a deeper understanding, and through understanding, you get a closeness. So that's what I try to do.
A feelings filter.
Yeah.
But it's like not all the words that are coming out of someone's mouth, even if they think they mean them, they actually know why they mean almost. It's like you have to interpret that in real time. And I'm hearing this, or do you actually believe this?
Yeah. It's a good way to phrase that is intent versus impact. You might have a certain intent, but how is it impacting the other person when they hear it? Right. So I think that's important to talk about.
That's good. Have you seen a just a cultural shift or a greater acceptance of couples therapy? I feel like growing up, our idea of couples therapy in our generation was
parents hate each other.
Yeah, it's like your parents hate each other, or
end.
you're going to couples therapy at the very end as a last resort saving grace moment, and maybe you'll stay together, but you're probably going to break up. But I feel like now things have shifted.
I think it is. There's still that stigma, because a lot of people will tell me, because I'll say, hey, it might be worth you guys going to couples therapy. If I'm seeing somebody individually and I'm hearing about their partnership, I'd say it might be a good idea for you to go see somebody together just so you can talk about this. And they're like, well, doesn't that mean things are over? I'm like, no, actually, this is a good way to foster closeness, to understand each other. And it sounds like you're missing some things. So it could be really helpful to have somebody lead you through that conversation and be able to help you have that conversation.
Our premarital counseling that we did was such a surprise in the best of ways. Just like having someone come up with a framework that they work with multiple couples, and even for the things that weren't applicable to us, like, great, no, we don't need, like, let's focus on these things. Huge.
Yeah.
Like, we've recommended that to many people.
So many people.
Yeah. And as a psychiatrist, I always get suspicious when a provider has not had their own experience being a patient. So I've gone to couples therapy.
Yeah.
I've gone to individual therapy, and I still do. I've gone now for almost 25 years.
Wow.
So
A little longer than you've been.
Yeah, longer than I've been
Yeah.
a psychiatrist. So I do think it's important. I think it's absolutely important to go to these things.
And like, in that 25-year arc, like how like often do you feel like you need to switch or find something new?
It's a great
It's
question.
just personal, but for more people, I guess.
And I think this goes into a bigger topic too, which is how do you know you're with a good therapist, or how do you know if it's somewhat of a good fit? And I think a good fit is when you feel like you can be you, and this person understands you, and they're curious about you. They want to know more, and they want to help you figure these things out that you might want to figure out. Not what the provider wants to figure out, but what you might want to pursue. And they might lead you down a path so that you can understand things maybe you're overlooking. But I think when you feel comfortable, you don't feel like you're being judged. Or if you feel like you're being judged, that could be a sign if you feel judged everywhere. So let that come up. It's an environment where you should be able to say, I feel like you're looking at me like I've done something shitty here.
Yeah.
And please, like, that feels bad. And that opens up a huge door. So I think a place where you can talk about anything and everything and feel comfortable, that helps you know it's a good fit. I think when I had to change, there were different reasons. It could help for a certain amount of time. That approach might have helped. I've seen a CBT provider. I've seen somebody who's a psychoanalyst, meaning they look at more the unconscious, what you're not necessarily aware of, but experiences you've had in your life that might color how you see the world. And that's the bend I take, is that people have had experiences throughout their life, often in childhood, that create a sense of how you see the world and how you interact with people. So I've seen analysts, I've seen CBT providers, I've seen a whole bunch of different people providing different modalities. It had to be a good fit. Sometimes I was moving away, and this was pre-Zoom and all those things. But I think somebody that can really get it. I really enjoy now seeing a psychiatrist who's been in practice for a long time, because I can also say, I had this experience this week with a patient, and I'm not sure how it affected me because it actually made me think this. And then they can understand from a provider's point of view, and they can understand from trying to help me since they know me as a patient.
Right.
Interesting.
Right. When do you know when the modality is a right fit as well too? So from my personal experience, I have done EMDR where I had two
What's that
separate. So, Dr. Bender, what does EMDR stand for?
I'd have to look up the exact. It's
Electro.
It's eye movement.
Something rapid,
All right,
maybe?
so what do we got?
Yes.
Let's look it up.
Is
We'll have
R the
to-
rapid?
Shoshana, you got it for us.
Yeah,
We'll have to look up EMDR because I don't practice EMDR.
Yes,
I have a lot of
yes,
respect
yes.
for my colleagues do, and I refer out for that. But it sounds like you tried that as a modality.
All right, Sho, what do we got?
Eye movement desensitization and reprocessing.
I was wrong on rapid.
Okay.
It just felt because we're
Wait,
doing the
say it one more time,
rap-
Sho?
Eye movement desensitization and reprocessing.
In your field, do you guys just name things as most complicated as
Yes.
possible?
Yes.
Yeah. I mean, we need a branding lesson.
I
Like,
know.
that's
We do need a
terrible.
rebranding on EMDR.
Yeah, but so EMDR, eye movement desensitization
And reprocessing.
What did you have to do for that?
So she essentially, it was a timed segment, like a short time, maybe like 60 seconds, where you have a specific thought or trauma, and you're moving your eyes back and forth. You're following your finger, going left, right, left, right, left, right, and it's supposed to reprocess the memory and take you down a series of what it connects to. Am I on
Yes,
the
you're on the right track.
Yeah.
And there's actually a similar thing. I see some professional athletes. There's something called brain spotting, which is similar, where there's an item that's held in front. And then as the provider, you look and you see when the person has some kind of reaction in their eyes, and it suggests maybe there's something there. So you focus on that spot and you get them to talk about what it is that they're going through, or what they were thinking, what they were feeling in that
Right,
moment.
over that spot, yeah.
So with EMDR, it's similar. You're trying to help the patient process what they've gone through. It's often used in trauma situations or people who have a history of trauma. What I find for my patients is I don't stick with what's called a manualized treatment, where for some CBT, if you do a strict manualized treatment, it's this week we do this, next week we do this, third week we do this. This is the homework for fourth week. You do 10 sessions and that's it. I take elements of CBT, elements of DBT. I'll take elements of trauma-based narrative therapy. I'll take elements of all these different things and try to tailor it to the person that's in front of me.
Yeah.
If I think a CBT technique will work or help somebody, then I'll use that. But I think when you're looking, it's hard because people often don't know what good therapy is like.
Yeah.
And I think if you feel like you're getting any better, one of my previous psychiatrists said to me, because I was asking him, like, when I'm with a patient, how do I know I'm doing a good job? And he said, after that first session, you want to leave the person with a little bit more than they came in with.
Mhm.
And if you feel like that happens, you're onto something. If you feel like that's not happening, especially after the second, third, fourth session, I encourage you to bring it up to the person. And a lot of times a good provider will say, you know what, I don't think it's a good fit.
Right.
Actually, let me refer you to somebody else.
Yep.
And I tell people a good consultation is 3 or 4 meetings of about 50 minutes in length for me to get a sense of things.
Wow.
But I also tell them I have no interest in wasting their time or resources. So if they come in and it doesn't feel like a good fit, even after the first or second session, I'll stop and say, you know what, I don't think I'm able to offer what I think you would benefit from.
Do people ever take that poorly? Almost as like, I'm
Sometimes-
being fired?
Yes.
A break broken
after-
up with.
Yeah.
You know, usually in the first session, if it happens the first session,
Yeah.
even 30, 40 minutes in, I don't charge them for that session. I say, look, I'm not going to charge you for today. I think it's important that you go see somebody who can focus on this because this is the sense I'm getting. And I've had patients say, but I have money. I'm like, no, it's not about you paying me. I really want people to come to see me. I want them to get the help that they need. And
Right.
I don't ever want to do someone a disservice.
Yeah.
So if I feel like I'm not the right fit, I'm going to let you know.
Because there's times in my life where if that one session had gone poorly, now I know, not for me. Like I would have made that decision so quickly. I know that in my teenage years. Like, oh, stupid, not for
Yeah.
me.
I'm really bad at breaking up with people in all respects of work, life, romantic. And I had a hypnotherapist. I had a friend recommend me to a hypnotherapist. And I was like, you know what? I'm open. Let's give it a try. And I had a panic attack almost every single time.
Wow.
I think around the loss of control. You know what I mean with the hypnotherapy, and it took me so long to be like, you know what, this is not the right fit. This is maybe not it for me. And CBT ended up being
That's great.
the answer for me. But
You're
I
booking an
went
next calendar
through
appointment.
even the EMDR therapist, so nice and so sweet, and like checked off a lot of the boxes. Like was very curious and asking a lot of questions and genuinely cared. But it took me longer than it should have, I think, from the patient side to move on from those providers.
Got it. Yeah, it can be hard. It can be hard.
It's hard. We always talk about how it's like kind of like dating. I feel like it takes a few.
Yeah, I said that once. I was a guest on a psychiatrist colleague podcast, and he's like, I don't like to think about dating and patience in the same sentence.
Right,
but I was
right,
like,
right.
no, but it is. You're trying it out, and you see if it's a good fit.
Honestly, like you don't have to get it right the first time.
Yeah.
It would be weird to be like the first person you ever met and had interest in, like, oh, marriage.
Yeah,
Like, that's
exactly.
not how it works. I can't
Right.
imagine.
Yeah,
how
right.
it works.
How often does that work in the real world?
Not often.
If I had married my high school boyfriend,
Yeah,
Oh,
exactly.
don't even on that. Going back to screens and social
Yeah.
media for a second, as it pertains to relationships, I feel like everyone's screen time has become more of a conversation, whether you're a kid or you're an adult. How is screen time, in your opinion, impacting relationships?
I've seen articles where the headline is the third person in the bedroom, and it's screens.
Yeah.
I think that it can really interrupt relationships in some ways. Some ways it can bring relationships together.
Of course.
Like people love, at the end of the day, I get to have dinner, sit down with my partner and watch a TV show. And they like that. They can share that experience. But I think when someone's doom scrolling or going through the news and not paying attention to who's in the room, that I do see sometimes.
That's
And-
even like the second screen experience almost in
Yeah.
life.
Yeah. And I'll have to say, what about putting your phone down when you get home for maybe just an hour? Just be present for your kids and for your wife, husband, girlfriend, boyfriend, just for that hour at least. See what that's like.
Are there any tools that you've like seen actually work?
Basket by the front door is
Yep.
one, or even a charging plate by the front door. You put it there, you're done.
Yeah.
So that helps. Timers can help people get off. Because what happens is then it becomes a source of contention. Like you're always on your phone, get off your phone, or you're always on the iPad, you're always on the screen. So I think having something where right away there's a routine. You turn it off, you charge it, you put it away, whatever it is.
Yeah.
It
And I'm
can
like,
be helpful.
this is like stupid, but like at 10 p.m. every night, my phone turns black and white. And I
Nice.
can't tell you how much not having color at what I'm looking at makes it less interesting.
Hmm.
And like it's a little shift that it's enough for me to like not be interested anymore. So I don't have to like leave it somewhere else. It's just like, oh, it's 10 p.m. This isn't as exciting anymore. And so like I have to just not turn the color back on, of
Yeah.
course. But like it automatically does it every night. And I've been shocked at how much of a shift it's made for me. Like I feel like I'm going to bed significantly more on time and early due to the fact like there's just not one more distraction to keep you up.
Yeah. And then screens the blue light keeps you awake and makes your sleep not quality sleep. And I think that can also lead to disruptions in the relationship, because if you're not sleeping, I mean, that's why they changed the rules for medical trainees, that you couldn't work longer than a certain number of hours, because they realized it was the equivalent of practicing drunk.
Wow.
So if you are not sleeping, you're not present that way. It's another way screens are getting in the way if they're keeping you up at night. So just keep a good, healthy hygiene.
I love the word hygiene. That's great. Internet hygiene, phone hygiene. So if someone has a past trauma or is trying to navigate the conversation of their mental health, past or current struggles, what's the best way to go about that conversation with your partner?
Can I ask for a little bit more specificity? Do you mean like talking to your partner about even pursuing treatment? Or do you mean talking to your partner about what you've been through, or both?
I think both. I mean, both. I'd love to hear your perspective on both. But I think about how many people have something in their past that affects or has changed the way that they navigate their entire life.
Sure.
And so I think talking about those traumas, especially early on in a relationship, can be daunting, and it, is incredibly vulnerable. So like, what do you recommend for that conversation?
Yeah, I think there's something that because I see teenagers, I've seen trauma bonding be something that I think teenagers go to a lot of times, and even young adults, where like, if I just dump all this out there and tell somebody what I went through, it brings me closer to them. And that's not the case, actually.
Really?
Just dump it all out there. And here, you deal with it. Like that. I think that's not helpful.
Yeah.
I think if you can realize, I want to share this experience I had with somebody because I either feel alone with it, or because it does affect me and I want somebody, my partner, to understand that, because I think it can help them understand me and we can work better together. I think that's a good guide for, okay, I'm ready to talk to the person about it. But you also have to know or figure out, can my partner hear this? Or what are they going to think? What's their EQ, their emotional quotient, like IQ, what's their EQ? And how are they going to handle this? So I think knowing your partner, knowing what you want to talk about, and then if you feel like you're not sure how to do it, that's a good opportunity to talk to a couples therapist if you're along that far in a relationship. But you're talking about even in the beginning of a relationship, you can kind of say, there's some things that I just not comfortable with. I'm still learning, still figuring out about myself. And I think it comes from some things I've been through, but I really want to work on that. At some point, I'll tell you about that. So you kind of let them know that. Not that there's this big, deep, dark secret, but there's a reason why you are as you are. So I think thinking about, what do you want to get from your partner by sharing this? Can they offer that? And that will help you start thinking about it. And then just spending the time talking.
Yeah.
But like in my own brain, like hearing the words you just used, like I immediately thought to myself, well, I would want to be able to get to the point as the partner hearing that, where they'd want to be able to share that with me, which is like much more positive than, oh boy, what is this person dumping on to me? Or like, why did they like bring this up already? Are they not over it? But it's almost like I would like to get to a place where you feel comfortable.
Right, to
me.
earn it.
Yeah. So like it even sets the dynamic up well.
Yeah.
Yeah.
That's interesting, though, that the trauma dumping method is not the way to go always.
Yeah, it's not the way to go.
Because I feel like I've definitely had friends who are like, let me just tell you everything. And I'm just like, okay, that was a lot. That was a lot. Thank you so much for sharing.
I think if I don't know those people, obviously, but if I boil down what might have happened there, it feels like it's more for the other person and not for you.
Yes.
It doesn't do anything to bring you closer. So I think when you're with somebody where you actually feel like, okay, maybe this will actually build our relationship, it'll help them understand me, then that's when it's worth talking about.
It's nice to know that it doesn't have to be an all or nothing situation.
No.
Well, intent or impact, going back to that, like what is the intent of you bringing this up and how will that impact your actual relationship? It's huge.
Yeah.
I think this is probably niche to us, but also I've seen this kind of discussed online. The topic around continuing or discontinuing treatment or medication specifically for mental health. Like I've asked multiple health professionals at this point, like how do I get off stimulants? Like how do I get away from them? And I know with ADHD in particular, and not being medicated or getting off things, I think there's a fear of like addiction or things that can like bubble up or whatever. But for like Lauren, you have no interest in ever getting off what works. Like
I'd like to be medicated to the day I die.
Right. I meet some patients like that. So I think a good way to talk about this is whenever I think there's an indication for medication, and that's typically because people aren't getting through their days the way they want to. They feel like they've tried coping in different ways and they're still feeling the same things they're feeling or having the problems with attention, whatever it is, then there probably is an indication for medication. So we have a conversation about, okay, so in this case, I might think about medication, and we have a conversation about risks, benefits, alternatives, what are the potential side effects, And when I'm starting to prescribe a medication for someone, if they agree, I'm also thinking, when can I try this person off of the medication if they want to be off of it?
Right.
So like the long-term consideration.
Yes. People really want to know, like, how many times do I have to come and see you before I'm better? How many times do I have to take this medication before I'm better? And I will tell people, first of all, it's a slow burn. This therapy is a slow burn. This is not going to be like 6 days and you're done. Same thing with medication. There are guidelines out there that say a good trial of a medicine, say in the antidepressant category, which can include medications for depression or anxiety, because they're the same medications. A good trial is 6 months to a year of someone feeling better on the medication.
Oh.
So you get to the point of, oh, wow, maybe this is helping. And then it's 6 months to a year. Then you can have a conversation of, how do you feel on it? If you want to try off of the medication, we can try that. How do you feel about this? You have conversations. So usually around then. If we try to take the person off because they're feeling good, and the idea is that if they're on, say, an antidepressant, they're less anxious, they're less depressed, they might start to have a different lived experience and see they can live in the world differently. And then they start to trust that. So the idea is, okay, have you built up and worked on these things? You don't need the medication, which was part of treatment that got you from A to B. Some people look at it that way, and so they want to come off. Other people, like yourself, they're like, this is working for me. I'm not having side effects, and this is great. Keep it on. Then I am all for that. If that's the way, I've had people on decades-long medication. They just want to keep taking it. It's no problem. But I really let the patient be a guide and what I'm seeing be a guide. So if there are side effects that they're telling me or I'm seeing, we'll have a conversation about, maybe this isn't the right medication. Should we try something else? Or in your case, for stimulants, and again, I'm not offering medical advice.
But also, you wait, but like stimulants, wait 5 minutes. You'll know how they feel. It's a different game.
It is a different game.
Which almost presents more challenges almost sometimes.
Yeah, antidepressants, the classic SSRIs, SNRIs, or other medications, they take anywhere from 2 to 6 weeks to fully reach their potential. Whereas stimulants, if you take them, they work typically within 30 to 45 minutes. Some are 90 minutes later.
The prodrugs.
You know if they work. Sometimes it's the wrong dose, and you have to go up over time. When you want to stop, usually what I would make sure is happening for people is that they feel like they can cope with what they need to cope with without medication, that they feel like it's the right decision for them, and that they know we can always restart it and have it in your back pocket if you want to try that.
Yeah.
Stimulants are the first line treatment for ADHD. There are other non-stimulants that are out there.
This first line, this is a very recent, I've heard it and I didn't pay attention to it, but this first line treatment, which makes sense, it's first line. Like, what does that mean when it comes to medication?
It's the first category medication you go to when you think of a disorder or an illness.
Sure.
This is what we're going to do. So bacterial infection, first line is antibiotics. And then in that, there's a first line. Which one? So it's first line. What's the first thing we think of in the line of medications we go to? So first line treatment for ADHD is stimulant medication. So that's what you probably heard as brand names, Ritalin-based medication or Adderall-based medications. Those are the two main categories. And then there are other ones. So there's Strattera, which is, again, I'm using brand names because people see these advertised on TV, magazines.
Well, if you looked at the real name, it's like 19 syllables.
Again, the rebrand. We need the branding to be.
Yeah, so there's that. And there's another third line treatment, which is bupropion or Wellbutrin.
Yep.
So there are different lines of treatment. With stimulants, if you want to get off of it, it's not the kind of medication you need to taper like an antidepressant. You can actually just stop it. Yeah. You're fine. But do you have things in place? Do you have the scaffolding in place? Do you have the timers in your phone, the alarms, the Post-it notes, all the stuff? And then, okay. Because the last thing you want to do is come off a medication if it's going to jeopardize your relationship, your job, your well-being.
And these are all things if like anybody who's trying to make the shift in a healthy way is hoping their best don't happen. And I think it's so easy to feel like guilty and shameful if, oh, I was wrong. I do need to be on these. I've failed now that I've gone back. Like I already like see myself giving myself like the self-pity show of like failing at these things and then not even wanting to admit that to myself.
I would have to ask a lot of questions more about you to get into that. But I think one thing that might be helpful then is try not taking it on the weekends.
Yeah.
Try not taking it. They do what is called a med holiday. If you're going on vacation, don't take it. What's it like? What does Lauren think of that? And that's important too. So there are times when...
Are you eating and doing nothing?
Exactly. And I'll see that. I'd be like, you got to do more than this.
Yeah, why are you horizontal 22 hours a day?
You haven't done any of these things I want you to do or that you need to do. Yeah. So
you went to the bathroom today? Yeah, it's fair.
I love what you said though about like having the scaffolding in place. Like I think about the very first time that I got on an SSRI, I think that like 2 to 6 week window is totally was my lived experience as well too. And then while doing therapy simultaneously, it's like I was finally able to Like my brain now had the space and the clarity to even accept the words that were maybe just bouncing right off or going in one ear out the other when I was living in such like an anxious state at all times. And so like it even allowed me to just even accept the most basic of understandings of the therapies that I was teaching.
Yeah.
Being taught.
Yeah. And that's the whole idea of can some of these medications jar you so that something comes loose enough for you to actually try something different,
Right.
to think about things differently. SSRIs, there's some data that, first of all, SSRI, a selective serotonin reuptake inhibitor, long word.
Again,
meaning,
guys, come on.
I actually even knew that one. I was ready for that one.
long phrase, meaning these medications help block the reuptake or the attachment and getting sucked up into the brain really fast. They prevent that, so more serotonin hangs around. And with that, different things happen. And one thing that we've seen is that while it takes 2 to 6 weeks for people to really get the full effect, what can happen sometimes even in days is the way people process negative emotions or the way people see something. There's a study where people look at neutral faces. Those who are depressed see kind of negative things. After a few days, SSRIs, they're interpreting it much more positively.
Interesting.
So emotional processing can be different. And that can be really powerful to not look around you and feel like everything's negative all the time.
Huge.
Right. A common fear that I've even navigated from friends coming to me asking about my experience with an SSRI. I'm on an SNRI now. That's been great. But when I was on an SSRI, I feel like a common fear that people always brought up was the numbing of personality. I feel like you probably hear that a ton.
Yeah.
And so how do you navigate that conversation?
Sure. So I think just to clarify too, SNRI means it works on serotonin and norepinephrine, also implicated in mood. So you get a boost of serotonin. I'm simplifying by saying a boost of, works on serotonin and it works on norepinephrine. That's great. That can be really effective. How I approach the blunting of affect is the same way I approach all side effects. I talk to people about these are the potential side effects. Some people get some people get none. The blunting of personality or blunting of affect, what people describe is sometimes they feel like they don't get the low lows, but they don't get the high highs either. So there's a shortening of the range of emotions.
Yeah, the spectrum.
But what I say is if you don't feel like yourself, it's not the right medication.
Yes.
There are plenty others we can try and we should try because I don't want people to not feel like who they are. Certainly stimulants can also have that effect.
Yeah.
If you're on too much of a stimulant, people often think, oh, I'm going to be bouncing off the walls. It's the opposite. You're actually dumbed down like a robot and you don't seem like yourself. Zombified.
Zombie mode.
Zombie that can't sleep.
Yeah.
Zombie that can't
Yes,
sleep. Yeah.
exactly.
Like
Can't eat
dead,
often,
but also
so-
like food. What? No, isn't it like weird? Like to the point where it's like at a certain point in time things break and almost become the opposite of them. It just I can't imagine interpreting that. Something I'm really interested in specifically for anyone who's not seen some of the work you've done on YouTube. Just search your name. Some of the things you've done are the most entertaining ways to learn about our brains, and so through that, I'm sure the work you've done that is most like public. It probably differs a little bit from what you were taught in the sense of like how to speak about these things in a less buttoned up and almost only educational way, but like how to make it entertaining. But how do you, I guess, as someone who's been in the field 16 years now, how has your brain changed in the way that you can compartmentalize some of the things that people are sharing with you that might be really heavy? Just to hear you even talk about the show on HBO,
Euphoria.
Euphoria. Hearing you almost speak to the things of how difficult it was for you as a professional to hear and see what was going on and not like be able to reach out and help. What is the difference between the way that you were taught to compartmentalize and now that you've learned actually works?
That's a really poignant question for me because I sometimes tell my patients this. I rarely reveal anything about myself unless I think it can help a patient. But that idea of being who you are is so hard for people sometimes in general to be who you are. And I found the greatest lesson for me was actually starting my practice to do that because I came out of residency. That's the training you do in whatever field you pursue after med school. I came out of my residency and out of fellowship and out of the other fellowship. And I was exhausted. And I was like, I don't know if I want to do this.
Wow.
And I started a practice and I was not enjoying it. I had all these rules I was supposed to follow in my head. I'm not supposed to say this. I'm not supposed to act this way. I can't ask this. I got to make sure I'm buttoned up. Somebody asked me, do I work out? And I got to figure out how do I dodge that question. It was weird. And then I realized a couple of things. The psychiatrist I was seeing at the time for therapy, I said to him, frankly, I was like, this is terrible. How do you do this job?
Wow.
And he said, you know what? I think you need to put more of you in your practice. He said, you're following all these rules. Just put more of you in your practice. So I instead of having the art on the walls that make people feel really like abstract and like
Right, yeah.
distant, I was like, I'm going to put a picture of Darth Vader blowing a bubble and it popping on him. I'm going to put a picture of Willy Wonka in the chocolate factory up. I started to put on the walls what I wanted. And I started to talk to people the way I felt like they needed to hear or that they needed. And it was so much better. And I felt like I could really interact with them. I could really understand them, and they wanted to come. My practice started to get busier because people are like, oh, this guy, you know, he's actually really genuine. And I always felt that was a compliment. I still feel that way. So I learned what do people need? Why do they need it? If it's something I can provide and it feels right and genuine to me, then I can do that. With the pop culture stuff, I found that that's the easiest way for people to start talking about mental health. Because it can be really scary.
Yeah.
But if they hear me talking about parenting in Star Wars, then they can be like, oh, I kind of went through that with my parents. I wonder what that would be like. Or if they hear me talking about Deadpool and grief, and they hear me talking about humor as a defense mechanism, then they'll be like, I kind of get that.
Yeah.
So then they're able to talk about it. Or if I say in a more, like a heavier topic, Darth Vader might have signs of borderline personality disorder or narcissistic personality disorder. People can learn about that and they're interested. They're not interested in a lecture where I'm going to give and they're going to glaze right over.
Yeah.
Right.
But
Here's
if
the
I
white
say,
paper.
like, I don't know if you watch Deadpool Wolverine.
Of course.
So
Yes.
I still want to put this out on a podcast or on something I do myself
Yeah.
too, but I'll break it here. I think, remember when they went into the void?
Yes.
The void to me is a great analogy for depression. People felt that the versions of themselves there were not good enough. Jennifer Garner's version of Elektra was banished. Like Channing Tatum's Gambit, not good enough to make a movie about. Like the version of themselves, they felt terrible. And then when Cassandra's reaching into Deadpool's brain, like that's the way people feel. Like, what is going on? This is not my brain. This is not how I think. It's not how I feel. So I think all these different elements there. So if I say that, rather than talk to you about, well, in depression, you know, we believe that serotonin
Right.
causes BDNF to go up, and then the TRK2 receptor,
Glazed.
yeah, exactly. But if I talk about this other stuff, they're like, oh, really? That's really cool. So I want to know my audience both in the office and outside the office. And
Yes.
figure out how do I talk to them.
Also, if someone comes to sit down and they look around your art and they go, this is inappropriate, I don't want to talk to this guy, great.
Yeah.
They didn't waste
Not the
6
right
hours.
fit. Yeah.
But it's
Yes.
like, I sit down and I go, this feels different. I like this. I see these things. I know what these things mean.
Yeah.
It's like, I think we've all gone to the doctor's office and seen like the skeleton hanging in the jaw and everything. And it's
Yeah.
like, I know I've got one of those, but like, I don't actually want to look at that at all.
Yeah.
I don't know. It's like an immediate, one, connection. And two, it's like we've kind of understood these things in our own way. And like, I can interpret things through it.
Yes. And I'm so thankful for learning that lesson. I wish I learned it earlier in my
Well, your
life.
professor
'cause-
told you that was stupid too. So.
yeah,
Yeah.
exactly.
Yeah.
So I wrote books that I hid behind a pseudonym instead of putting it out there.
Wow.
And it was popular. It was mentioned on The Tonight Show. It was number 11 on Amazon. But
Wow.
I didn't come out behind that because I was
Because-
thinking, well, what are people going to think? But again, I want the people that like that to come to see me. Like
Right.
that's going to be a good
You
fit.
were psychiatrist Hannah Montana.
That's a good point. Never thought about it. I scrambled H. Eric Bender into Rich E. Drieben. So
Okay.
there were a couple books under that.
That's cool.
That's
That's really cool.
Wow. And also, Bender's such a great last name.
Thanks.
Yeah.
Next book, Bender.
Yeah.
Has to be
thank
Bender. Yeah,
I
you were
do that.
living Hannah Montana and it wasn't working.
Yeah, no, it wasn't.
Wow. I can't believe no one ever has Hannah Montanaed you for this metaphor before.
Well, you're the first. It's great.
So we wanted to ask our audience some questions that were applicable to their lives while we have the opportunity to chat with you. And so some of these I'm gonna give you a warning now are a little out of left field, and we'll get to those mid question
And don't ask
list.
more context.
I live in left
We don't have
field.
it. We don't have it. Yeah.
I live in left field. So
But this is a common one that I feel like the word narcissism gets thrown around a lot and people have been misidentified, and it's kind of just become like people, when you see someone that's full of himself, is called a narcissist. What's happened to the word narcissism?
yeah, it has kind of been reclaimed in these different
Yeah.
ways. I think an even simpler idea is that a narcissist often thinks of themselves and has these ideas of unlimited power and beauty, and they're going to pursue that. And on the most malignant end, they even call it a malignant narcissist, someone has a lack of empathy. They're just using other people as pawns to get what they want. That's more the psychopathic side of things. But the idea, I think, behind it that gets maybe oversimplified and used in that, or referred to by using that word, is someone thinks only of themselves, no one else.
Right.
And they take up all the room. And there are different ways that this happens. There are different types of narcissists. It's a fascinating field. But there's the vulnerable narcissist, someone who at the core is actually really fragile. And you feel like you have to keep propping them up in different ways. You need to do things to make them feel good. And that's different than what's being referred to online as the narcissist. But something that I tell lots of patients is there's a difference between being selfish and being self-protective and self-interested. Selfish, you only think about yourself. Nobody else fits. But being self-protective, you can think about what you need. Being self-interested, you can think about what you need, and you can think about what other people might need also. So I think if you can look at that lens, like, all right, is this person only thinking about themselves? Is it to the point where they're using me in a way to get what they want? Maybe that's more of a true narcissist or someone who has narcissistic tendencies.
Can narcissism overall be genetic?
You can have, I say yes. So genetics are part of mental health for sure. I also think there's an environmental piece, particularly in what we're talking about, which are personality disorders.
Right.
And a personality disorder means that the way someone interacts with the world is vastly different than the cultural norm. It often can come from experiences they've had, trauma. Sometimes it is genetic. Sometimes there's something there. A family that might have more of, say, a flair for the dramatic. Maybe you have more histrionic people, if you use a psychiatric term there. So I think there can be genetics. But when you talk about personality disorders, it's often experiences people have had, boundaries have been broken.
Right.
And you can also have personality traits, not the full disorder. So you can have narcissistic traits, or you can have traits of histrionic, which means you're extra dramatic, or you really like to be the center of attention, or as someone with true histrionic personality disorder needs to be the center of attention. Think about Harley Quinn.
Yeah.
So she needs to have this persona, this costume.
She's
this
in
way
the
of
room, you
talking.
know it.
Yeah.
Yes.
So you can have these traits, doesn't mean the full personality disorder. And sometimes it is genetic, but I often think, well, if that person's like that and you're growing up with that person seeing that, there's also the environmental impact. And is it genetic? Is it nature? Is it nurture? Not sure exactly.
I don't know if you've ever seen the comparison where there was two twin sisters who were about age 50. One had gotten Botox and one had never gotten Botox.
You seen this?
I haven't seen this.
Oh, it's fascinating.
It's so fascinating. So essentially one looks considerably younger, obviously, and one has, been in the sun and their skin looks totally different. So say there were two identical twins who had a very similar genetic makeup and had lived the same childhood and experiences. If they both had depression and one went treated and one went untreated, what would that look like in the actual brain?
That's a great question. And we're starting to get more images of what happens in the brain. So in someone depressed, they have less transmission of serotonin in certain parts of what's called the limbic system, which is what processes emotions. So in the midbrain, that's part of it. In the amygdala, that's part of it. You might have less transmission of serotonin, again, suggesting that serotonin has a role in mood. So things that would light up in the brain in the person who's been treated, areas that actually show some changes. And we've seen this too. Imaging shows changes of structures in the brain. We can't say that causes them to be better, but this might happen. You probably wouldn't see that in the person who's been untreated. You wouldn't see those structural changes. You probably would see the decreased transmission of serotonin in certain places.
Wow.
So
It's like this, the things that talk to each other are just more dull, or
yeah, and actually that's a really good way to put it, because we've seen that there are pathways that serotonin are involved with. And yes, those pathways talking to each other one step to another, they're not functioning in some ways as robustly as someone who's not depressed.
right. It's interesting. And obviously it's probably very difficult to find people who are depressed at certain ages that are also twins. And
This is, I'm sure, a nearly impossible example.
Yeah.
We were just curious on what that would look
And I
like.
think the Botox example is so easy for us to see.
Yeah,
It's like,
because it's on the outside.
Yeah, it's crazy just to think about just like how different someone's even internal organs could look or react or even just work, despite the fact that they did start in the same place.
Yeah, it is. And I think an important point, an offshoot of this is what tells me and tells us that it's more than just genetics, that's mental health, because you can have twins where one has schizophrenia and the other doesn't.
Right.
So it's not
My
100%.
stepdad, I was like this. One had schizophrenia and they were twins.
Yeah, and the other doesn't. So there's something else. Maybe it's environment. There's something called epigenetics where something turns on the genes to actually show in your being something. And maybe something happened that turned that on in one person, not the other. We don't know. But that's what tells me it's not just genetics, but there would be something different over time.
What do you think about the genetic mutation tests that are starting to gain popularity?
So the American Psychiatric Association, APA, said while that's a good thing, a couple of years ago, they said there's not enough evidence to show this is something we can say will guide our treatment at that point. However, why not try it? If it's telling you this person's enzymes or what are going to metabolize their medications in their system are not as strong in this area and they might respond better here, why not try that? Sure, I could start with that, but I'm not going to use that as gospel to say, I can't ever try this. Because I've had some patients say, well, my printout here, I'll show you, it says I can't take an SSRI. I say, well, why don't we try these others? And then we'll come back to this and we'll see how you do. So
what was yours?
Yes, mine came back essentially. So I had been on an SSRI for 9 years and had essentially upped my dose to the maximum over the years and switched over to a different SSRI, wasn't successful on it. And so eventually it was kind of like a decade into my journey. One of my psychiatrists was like, let's try this test.
Yeah.
And it essentially came back that the way that I metabolized serotonin, I think was just more active than what it should be. And so that's what led us eventually to, well, first we went down a not
Small
first
detour.
line. We had a little detour and it was not a first line approach. It was probably like fifth line. That did not work. And that was the 10% of life area. And then eventually, when he suggested the SNRI based on like, okay, this is still working on serotonin, but also the norepinephrine now. Maybe this will be a turning point for you. And it was. So it did end up being a great tool for me, but I know that I've heard, I guess, that sentiment echoed and just wanted to get your perspective on it.
Yeah, no, and I do use it. I mean, I'll look at it even the other day. I was looking at someone's and I said, okay, well, it shows maybe you're hypermetabolizer of this, so we might need higher doses, but why don't we start out with the regular doses and then we can see what happens. So that's how I use it. Not as like, you can't do this and can't do this, but they might have a different response to these medications, be aware of it, and then figure out, do we need to go higher? Do we need to go lower? What should we do?
Yeah. What's going on with a brain zap?
So a brain zap is when you're coming off of a medication.
Yep.
Even if you taper, there are certain medications that are known more than others to be harder to get off of. It's this feeling like electrical activity in your brain that just goes through it really quickly. And it's part of a withdrawal syndrome where as you come off the medication, your brain has become physiologically dependent. It doesn't mean you're addicted. It's become physiologically dependent upon that medication. And when you don't have it in the amounts you did before, it's reacting. And some people think, well, maybe you've upregulated receptors over time, and now those receptors don't have the serotonin or the norepinephrine, and that feels weird. But that's a result of a withdrawal syndrome. And it's important to note, not everybody gets that. There are some medications where even if you taper down slowly, the way you should taper up when you're taking it, about 30% of people will still get it with certain medications, or you might experience it and there are other things you can try to do. Sometimes you give a longer acting dose. You give a medication that's longer acting, one dose of that to help you through that. But that's really uncomfortable for people.
Man, I was in the 30%. That hurts. That hurts to know that I was in the 30%. I was like, that's actually less common than I thought you
were
were
in the top
saying.
30%.
I was in the top 30%.
Yeah.
I know. I tried to explain to Jeremy what it felt like. I was coming off of Zoloft. This is again when I was coming off the SSRIs. And I was trying to explain that it just feels like the center of your brain is being electrocuted for a millisecond of time. And it is so jarring because it's such an unnatural feeling. Because I've never felt the center of my brain. I don't feel my brain at all. But right now, I'm feeling my brain.
Yeah, no, totally. That's a great description of it. And there are some people that I've seen that have actually bought scales, like medical grade scales, not for illicit substances, although some have done it for that. But they buy it, and they will literally count the beads down in the last couple of weeks just to go down that slowly.
Yeah.
And what I'm imagining happened to you, I don't know, but you can, as you get to the ceiling of certain medications, over time, there's something called Prozac poop out, which is that category of medication.
See, now
That's a
there
great
we go.
name.
Where's this name?
That branding, A+.
Yes, where the medications that are SSRIs over time, sometimes for some people, don't work as robustly as they did before.
Right.
So you have to find a different medication. That's possibly what happened to you after 9 years. But either way, it's great you found what worked.
I Prozac pooped out.
You did. I love this question, and I would love to know who asked it. But it's quote, how many voices in your head is a normal amount? End quote.
that was all the context that we got.
All right. So I think
We don't know this person.
I think we all dissociate in some ways. Dissociate, I mean, you're distant from the experience that's in front of you. How many of us have listened to music in the car and then suddenly we're starting to think about what's there and you don't hear the music anymore? Or you dissociate when you go watch a movie. Like you're not in your world, you're in somebody else's world. You're in another world completely. So I think there are times when it's totally normal to not feel in your body. And in terms of voices, we all have voices that tell us things. you can imagine your mother, your father, your aunt, your uncle, all these people saying, what are they going to say about this? What about this? So I think that's fine. It's when the voices feel like they're intrusive. Is it actually something that is almost being externally placed there, or you feel like you don't want it there?
Yeah.
That keeps you feeling uncomfortable.
Right.
But it's normal to hear. I can hear my wife tell me, "Oh, don't put your shoes there." Like I can hear that. So I think normal to have voices in your head when it feels like it's intrusive or uncomfortable, or what's called ego dystonic. Means it doesn't line up with who you are. Ego syntonic, it lines up with who you are.
But does that mean it almost feels like it's a voice and it's not somebody else? It's not your wife. It's like someone's telling you to do something that isn't in line with what you feel like you are as a person?
Or it could be yourself.
Yeah.
A lot of times in OCD, obsessive compulsive disorder, I hear people tell me, I feel like I have to go lick the doorknob. Like I have to go do that. Something's telling me to do that. Those are the more severe cases.
Right.
It's their own voice in some way.
To confirm that's not normal?
It's uncomfortable. It's like we all have, but we're humans. That's what distinguishes us from every other animal on the planet, is that we can think about absolutely anything and everything. But it's when you can't not listen that it becomes a problem.
Right.
Yep.
I met someone who had absolutely zero internal dialogue. Absolutely zero.
Wow.
And I was like, you know what? This actually makes so much sense, because she's such an engaged listener, because when you're talking to her, she literally is only listening. And so I stayed with her.
Like?
I stayed with her for a couple nights, and I'd be like, we'd be like doing our makeup silently in front of the mirror. And I'd be like, so like, what are you thinking about right now? Like what's happening? And she's like, oh, I'm like mascara, eyeliner, blush. And I'm like, oh, that must be so peaceful. I've had 14 thoughts in the last 10 seconds. I was like, what do you mean?
And your thoughts sometimes
Are
concerning.
Man. Okay, so we had someone ask, and this probably can be said more eloquently, but they simply asked, why can't I cry?
There's a lot of reasons why that might be the case. I would want to know from that person, so have you ever cried in your life? What was that like? What was that seem like in your family? What does it mean to cry? There's a thought that when we emit tears, it's actually a signal to somebody else that we need help. What does it mean to ask for help from somebody else? There's usually a meaning, at least I see, in all these emotions for people. What does it mean to feel that way? What is grieving like in your family or your culture? What have you been shown? What do you see? What does crying actually mean?
The symbolic.
Yeah.
It's interesting you say that, because like there was a period in my life where I did not cry for I think like 10 years. And it was because I didn't want anyone to like think I needed help.
Yeah.
It's not that I didn't feel like I was crying. And if I'd let myself, I would have cried. But like to not want anyone else to see that, it's like I held that in to the point that you just made, which was very, very light bulb.
I'm glad. There are also, of course, some medical reasons why somebody might not cry. Sure. There's something called Sjogren's syndrome, which is an illness where you actually can't. You have dry tear ducts and dry tear beds, and other things combined with that too. Some medications, that shortening of the range of emotions, people on medications sometimes tell me, I can't cry. I feel really sad and I can't cry. And that might be a reason to say, do you feel like that's holding you back? Because if you're not feeling these things, maybe we should take you off the medication, and those emotions won't be so terrible, because now we have this relationship where you can actually not feel alone with them.
Right.
So
I'm an ugly crier. I'd be okay with never crying again.
Okay.
When someone develops we can just use me as a case study for emetophobia. So like, what is happening in the brain when someone develops a phobia?
in terms of what's actually happening neurologically, neurobiologically, I'm not sure, but I'll tell you that when people have anxieties, and I think a phobia is an extreme example, we all have these thoughts where there's a pathway from kind of the back of our brain to the front that says, this is this thing you're worried about or you think about. And then there's an inhibitory pathway that goes back and kind of clamps that down. And in people with anxiety that's severe, the inhibitory pathway doesn't work so well. So you actually have all these anxieties and nothing's telling you, don't worry about that, don't worry about that, don't worry about that. So you keep worrying about it. So I think that is probably what's going on in part. Some of the pathways are not dampened as much as they should be.
Right.
But you also, some people, I don't know about you personally, but some people will have had experiences that were really traumatic for them around, say, vomit, or around, say, being sick, or people dying, being sick. And that whole area of hypochondria is very interesting to me. What I often see with patients with hypochondriasis, meaning that worry that you're going to be sick or that you are sick, it's just different than emetophobia. It's just a worry you're going to be sick. Is I think often those people have a wonder, often those people wonder and they're worried, like, who is going to take care of me? They're often in positions of taking care of others.
Right.
And the only way they can even imagine somebody taking care of them is if they're sick, but then they get scared, like, who would actually do that?
Right.
So there's often something psychological underneath all
Which
these
is,
things.
would not be obvious, I feel like, to someone going
Yeah.
through that. Like they wouldn't want to
No.
admit that like they're worried about not having someone to take care of them.
No.
Especially if they've got to be strong for somebody else.
Exactly. And so that unfolds over weeks in therapy.
Your job's
we're talking about
complex.
it.
Yeah.
God.
Wow.
Yeah, that's just like you're like it's like again, it's like you have to like listen to everything, yet know what to like push back on when someone's obviously telling you this is how I feel. And it's like I know that's how you feel, but this
Yeah.
there's a lot there. What's the difference between OCD and being a very organized Type A individual?
I feel like social media has really taken that
Yeah,
one
this-
and run too. Yep.
This is important to know. The difference between obsessive compulsive disorder and type A personality.
Yeah.
Obsessive compulsive disorder, you have an obsession, you have a worry. Classic example is you're dirty. The compulsion is the behavior you do to get rid of that worry. So you wash your hands. And that's OCD. There's this obsession, a compulsive behavior to get rid of it, and it repeats. Oftentimes, most often, it's really ego dystonic. It's really uncomfortable for the person. It doesn't feel like who they are. And that's what makes it the disorder, is that they might spend more and more time doing it when they don't want to. Checking the stove, checking things, counting things, lining
Right.
things up, touching things a certain way. Like those are all examples of OCD. Type A is someone who probably has more what's called obsessive compulsive personality disorder traits, OCD
Oh.
versus OCPD. They have certain rigid ways they're going to do things. They're going to do it this way. And if it's not done that way, it's not okay. The classic training on this we got was OCD is you're uncomfortable. You're really uncomfortable with this stuff. OCPD, you make other people uncomfortable. So that's how I always distinguish it.
That's
That is incredible.
That's pretty clear.
Yeah,
That's
that
pretty
is
clear.
crystal clear.
But to your point, like there are some people who like, I do it this way. I know no one else does it this way. It works. I'm not changing. And like, it doesn't really impact other people.
Yeah.
It's just like, why do they do it that way?
Yeah.
And like, and to your point, like when you can't help but do things that are normal in a way that just aggravates everybody else because how anal you are, that does just like make it
Those
clear.
are sometimes the make or breaks in relationships
Yeah,
too.
you're
Is that like
you know
I've
what?
got a way that
is
this
who
has
you
got
are.
to be done.
I know it's not changing. Whatever.
And I talk a lot about this with people who are dating. I see a lot of people dating. I have a medical license in New York, Florida, California. I have
Nice.
people dating in San Francisco and New York often. And what I find I have to say is people are who they are. How much of this will you tolerate? Like, do you fit
Yes.
in this person's life? Do they fit in your life? And when they're really rigid, we have to really look like, do you think they're going to change? Like, is this too much for you? And it's okay if it is. Like, they'll find somebody. There's a lid for every pot. Like, they'll find somebody who's okay.
Yeah.
But just think about those things. I think these things come up when people are
It's good
dating.
to be a little bit like self-protective in
Yeah.
certain ways. It's like, do you really want to be the person that they need? Because I don't think you do.
Yeah. And then the other side is working with the person who is that way. I'll
Right.
say, when you do that, I wonder what that's like for other people.
Right.
Or saying to a narcissist you asked about earlier, saying things like, I imagine that when you feel uncomfortable and you feel vulnerable, maybe you're doing things that come off like you're being a dick.
Yeah.
And maybe that's what other people are seeing. And just explaining it that way and exploring, like, how are you impacting other people too?
Right. A new perspective.
Yeah.
How common is serotonin syndrome?
So that's something that's pretty rare.
Yeah.
In my life, I think I've only seen one case of it, and I've been in psychiatry pretty much for 20 years.
Wow.
So I've only seen one case of it. It can happen. And serotonin syndrome is when there's too much serotonin in your system, often as a result of taking medication for psychiatric reasons. Now, this is not a reason to not take medication. I think people sometimes hear about a side effect and they're like, I'm not taking that. But I always tell people I would never recommend a medication if I thought the negative sides would outweigh the positive.
Right.
But in serotonin syndrome, this rare situation, when you start to take a medication or you go up on it, or more often when you take more than one psychiatric medication at the same time, all of which target serotonin,
Sure.
you can get too much serotonin in your system. And that can cause fever, rigidity, muscle rigidity. It's very uncomfortable, and you have to go to the emergency room. It's an emergency. So that's rare. The opposite. So imagine the people that have done MDMA the next day, they're like, I've depleted all
drained.
serotonin. This is the opposite end. It's too much.
Wow. What do they do at the emergency room?
They'll make sure your temperature's okay,
Oh.
IV fluids. They'll really try to watch you, monitor your
Does it
vital
like
signs.
cause heart attacks? Or does it,
Well,
like,
once your
lead to things?
temperature goes up,
Got it,
that's
yeah.
really
Right.
good
Like,
for your
it's not
body.
that. It's like the other thing that then
Yeah,
triggers something else.
Exactly.
You're
all
going to
that stuff
cook
that-
your organs.
Chain event.
Yeah.
Quote, why is everyone on social media claiming to be autistic? How has social media influenced the understanding in a colloquial sense? And how does it impact your job? End quote.
I feel like this is the bipolar of years ago where
Yes.
you'd hear bipolar in Katy Perry song and people are like, I'm so
Right.
bipolar. I'm like,
Well,
yeah, there's certain
so-
criteria for that. So I think the same thing with autistic disorder or autism. And this is also a space I want to be clear. I don't practice in that space. I know of providers and colleagues that do. I refer out for it. I have an understanding of autism from my child psychiatry fellowship and just reading about it. Usually what people are referring to is a rigidity, an inability to follow. Actually, let me think of the best way to say this.
And I'd love to know, but we can add this in later. Are there any good pop culture characters that might serve as a good example?
Forrest Gump?
Yeah, I think Forrest Gump was a great example.
Okay,
Actually,
yeah.
it's good because so some of his socializing was not always with eye-to-eye contact. He wouldn't
Yep.
pick up on social cues. Often autistic people will do that. They'll have that difficulty. And again, it's a spectrum disorder, meaning there's a wide range. Does someone need a lot of support? Does someone not need as much support? So there's a huge range. But typically what I think people are referring to is the social aspect of it, the communication part of it, where people might not pick up on the social cues. They might not understand when everybody's getting up from the table, like it's time to leave. Or they might not understand that if someone's telling a story, you respond to that story. Or if people are turning away from you, you don't continue your story. Like these are different things that might happen. So
Yeah.
usually people are referring to the communication piece of it.
I think the rigidity portion of it too, because like I always see people talking about like, hey, TISM talk. How do we feel about this spoon? I don't know if you've seen any of
Yeah,
those.
I haven't, but I can imagine you're right. When I think about it now, it's this is the spoon I use for this, and I have to use this, or I'm otherwise really uncomfortable.
She won't use a spoon over like 3 inches. It's just like she wants it to be
No,
small.
but I think it's incredibly common, especially like I just feel like I have so many friends who like love a smaller spoon.
Okay,
and by
yeah.
so many friends, you mean you?
No, I feel like it's a common lived experience.
Totally. Yeah.
I'll back you, Lauren. I'll back you.
Thank you so much.
Small
for that.
spoon
yeah,
talk?
I live in the large spoon world.
Okay,
I think
same.
people more tend to.
Yeah. We meet on Tuesdays. Yeah. But it's funny. It's like to your point, it is showing itself in that social way. And like working in tech, it's also thrown around in the sense that some of the most brilliant people have diagnosed themselves with
Yeah.
having autism. And I don't know whether that's valid or not. But to be fair, I wouldn't want to like work in a quiet room by myself, staring at binary all day and
Yeah.
like get fulfillment from it. Like that's not something I would relate to, and they seem to.
Yeah, I think it's important to know neurodiversity is fine. You know, there's
Yeah.
it's important to recognize that there, and to understand how people do communicate. So how is it best?
Externally, we're all
Yeah.
different.
Yeah.
Yeah.
No one is the same.
How common is it nowadays in the population for someone to be completely non-neurodivergent?
There are a lot more diagnoses, I think, of ADHD coming up. I think I know when I was in training, it was 4 to 7% of kids might have a diagnosis. And now I think it's bumped up even more, closer to 10% even. I think that we're more aware of it and we look at it even in adults. It used to be that, you have to have had ADHD symptoms as a kid to get a diagnosis as an adult. And that's not the case anymore.
Yeah.
So there are more diagnoses as adults. I think also with ADHD in particular, stimulants work. It's why they're highly abused on college campuses.
Totally.
They're not, side note on stimulants, they're not addicting when they're used properly, but there are side effects. It can really affect your heart rate. It can affect your appetite, sleep, headache. You can have hallucinations. So these shouldn't be taken without a doctor's prescription.
I've taken a lot of Adderall over my 10 years. I've never seen anything.
Yeah.
Like if you're seeing things,
Yeah, right.
something's wrong. Yeah.
Yes, exactly. So I think it's important to know that all this can happen.
Right.
But in terms of the amounts, I'm not exactly sure of all the diagnostic. I'm not exactly sure of the percentages for those things.
Yeah, because it seems like the criteria for a lot of the different categories of mental health on the spectrums have been changing. And so, I think that makes sense.
But like hearing the way you talk about these things and how to identify them, it really does feel like at the end, it's like it is up to your gut and your knowledge, your experience, what you've seen, what you haven't seen, to be like, I'm going to make a call here that can change, but like you have to make that call.
Yeah.
And there's not like, this is the test. You have this disease.
So but that's important. I'm glad you brought that up. There are some what are called measures for different diagnoses.
Yeah.
So for ADHD, there are certain screens and certain questions, and I'll give them out to spouses or partners, or the individual themselves will take these things, teachers. So I'm getting information.
You looked at my report cards. You go, yep.
Yeah. I've actually asked people.
You
do
wouldn't
have
need to
report
ask me.
cards? So you look for the comments, but there are also questionnaires, different forms people have come up with for ADHD, even for autism, diagnosing that. There are all kinds of scales. You give parents, you give teachers, you do fill this out because you don't want to just be your gut call, because some people can be like, well, yeah, it feels right. And I think, sure.
Right.
And I do a lot of that.
Confirmation bias.
I do a lot. Yeah. But I do a lot of that. But I do want to gather as much as I can. And sometimes that means talking to partners about things and not using a measure, but getting another perspective.
Right.
A lot of times you're right, though. I can come in and I can sit with somebody, and I usually want those 3, 4, 5 sessions because somebody can look very different first day than they can the second, than they can the third.
Totally.
So I want to understand. And then there'll be people where I've had this one idea, and then 10 sessions later, I'm like, oh, this is actually going on.
Right.
And I'll
Right.
say that something like, I think you have a pretty significant history of trauma, and all this stuff fits in PTSD. I think that's a more accurate diagnosis.
Well, I think a lot of people wouldn't want to offer that up in the beginning because that can't possibly be why they feel that way. Now, I'm not speaking from experience by any means, but yeah.
Well, there was a point at which my youngest patient was, I think, in the single digits, or maybe 11. My oldest was 91.
Oh,
And the 91-year-old in therapy was telling me, I've never really told anybody this, still at that age.
91.
In 91. So I took that as a compliment. Again,
Yeah.
I feel really great that somebody's that comfortable, but it does take a while to share these things.
Yeah.
So
Yeah.
it's important to
And
leave
even
space.
internally, like, oh, this is something that I can share, should share, want to share, and I'm like comfortable doing.
Mm-hmm.
I'm sure it also happens a lot too, where someone has entirely suppressed or like blacked out a period of their life if there's trauma, and it takes that 10 sessions of building that relationship for it to even be unlocked in their brain to even tell you.
Yes, exactly.
To end on something a little happier, what happens to the brain when you fall in love?
We've heard about the oxytocin. It's this natural chemical in your brain that starts to make you feel better. And actually, women have the same increase in oxytocin when breastfeeding their babies.
Wow.
Oh, wow.
There's an increase in that. So there's this bonding hormone that happens. And you have just different ways of seeing life. You start to see life more positively. There's something bigger than what you've seen before. I don't know if the studies that look at structural changes, but I'm sure that there are things that are changing in different ways as you first go through that phase of like being smitten by somebody, and then you go through the phase of really settling in with the person. But I definitely see that. I've had patients who were really depressed, feeling really isolated, alone, and then I see anecdotally, or I see physically, that they feel better about themselves. They're carrying themselves differently.
Right.
So
Like some people that have never gone to the gym, have never done this, have never done things that I feel like they're like outside their character, and like either it goes one way or the other when they're like in this new mindset, like new possibilities have like become like a reality.
yes.
And vice versa. And like it really did take something like completely unrelated, but obviously that has some correlation to it to like unlock this part of themselves.
Yes. Yeah.
Well, this was incredibly insightful.
Yeah.
Thank you so much for all of your expertise.
So where can people find you, and what are you most proud of that you're doing right now, and what can you talk about?
What I'm most proud of is something I just finished up, and I was working on the Batman Arkham Shadow video game.
Wow.
So that was really awesome. And they just did the final final upload, and that was in January.
And can you
So
speak to any of that yet or no?
I can. Yeah, it was great. It was awesome because the team at Camouflage, which works with MetaQuest 3, working up with Meta, they were so open to everything I was talking to them about. They had specific questions, and they were so open to say, "Oh, we didn't think about it that way."
So they were
And
building characters and wanted like real information to go off of.
They wanted additional psychological depth to their characters, and they wanted accuracy and accessibility.
That's cool.
And that was really, really cool to be a part of. I was very honored to be part of that. But the same thing, though, the top thing is what I said earlier, just being able to sit with people and feel so privileged to do that in these hours that are really hard for them, or where they've been struggling with something all their lives, and they realize something different because of something I said or something we came to together. Like, that's what I'm most proud of. I really love doing the pop culture stuff. That's great. I'm trying to work on podcasts. And,
Dr. Bender podcast
yeah,
coming
yeah,
soon.
Everyone get in the comment.
going.
Everyone bully him to make him get a podcast. Yeah, we have to get him in there. We have to force him that way because you have the way that you say things is very easy to understand.
Thank you.
And you do seem to like tie things together in ways that like make sense after you say them. But until you do, it's like, oh, I would have never thought about that.
Thanks. Yeah. So I think right now people can find me on YouTube. I'm going through a rebranding my website. The old one is up, but it'll be changing in the next couple of months at Dr. Eric Bender, all spelled out, DOCTOR, Eric, ERIC, Bender, BENDER.com. And I do get lots of emails. I'm happy to respond if I can. And yeah.
Oh, you just opened the floodwaves.
Amazing. I mean, you got a glasses collection that needs to be shown to the internet.
Oh,
so
thank you.
podcast
It's true.
coming soon for Dr. Eric Bender.
Thank you so much for coming
Great.
today.
Yeah, it was awesome. It was an honor. Thank you so
Thank you.
much.
Thank you so much. All
We'll
right,
see you all
guys.
next week.
Bye.
Bye.